ल म प्रेम पाठक हो है मेरो घर खास घर इट्स इन लुम्बिनी तौलेवा नजिकै हो एउटा गाउँ सोमडी भन्ने गाउँ हो काठमाडौँमा आई स्टडीड फ्रम 4 to 10 4 to A level भनौँ न उडान खण्डबाट त्यसपछि पाकिस्तानमा एमबीबीएस त्यसपछि अमेरिकामा यहाँ आएर साइकियाट्री जगदम्बासँगै गरे हो अनि त्यसपछि चाइल्ड साइकियाट्री पछि फेलोशिप गरेँ हपकिन्सबाट नाउ आइ एम वर्किङ इन नर्थ डकोटा धेरै cold place, not well known. अब यहाँ म चाहिँ एज अ चाइल्ड साइकियाट्रिस्ट काम गरिरहेको छु होइन आउटपेसेन्ट हेर्दैछु आउटपेसेन्टमा अब युजली बच्चाहरूलाई हेर्छु बट आई अल्सो सी अडल्ट्स एट टाइम्स but because that's my specialization and there's others who can see adults, they have me see the children. So one of the things I do over here, and I teach students also, and if you don't mind, I'll try to speak more in English. It just makes me a little more comfortable because I might not sound out some of the Nepali words right. But one of the things I do over here for the students is they come to me because there's not so many child psychiatrists, right? So they will basically ask, what can we do to make things easier or prepare the patient before we can send them to you? So like, you know, America ma abo child psychiatrist la thigai cha त्यसपछि psychiatrist and then we have like nurse practitioner त्यसपछि PA physician assistant यिनीहरुले पनि हेरेर हुन्छ अनि तिनीहरुको अब हुन्छ नि अब जहाँ धेरै प्रोवाइडरहरु छैन then you need more kind of, you know, some support. You need more time before you can get to the child psychiatrist. So what can they do in the meantime? So what I was going to do is I'm going to kind of make out a case, read out a case, and then we can discuss around that case, right? So let's say there's a 7-year-old boy by the name of अब अमेरिकाकै नाम हालौँ कि कहाँको नाम हालौँ डेभिड भनौँ न 7-year-old boy David, he lives with his mother and stepmother and he has a 3-month-old baby. Sorry, he lives with his mother and stepfather and he has a 3-month-old sibling and he has visitations with his biological father. Not uncommon here. त्यसपछि he has a family history of ADHD and depression. So he came to the primary care provider with various symptoms of behavioral problems like he's defiant, doesn't listen, is irritable, impulsive, not focusing well, doesn't want to go to school, is isolating himself, doesn't talk to people, doesn't play with others. And in the exam, he's very subdued, doesn't even make eye contact. It's very difficult to get information out of him. So that's the outlines of this case. Okay, and around that case, I can explain to you so many different diagnostic concerns that may come out. It would be nice if we could do like an interactive kind of thing as to get your opinion on, you know, what could be the possibilities, the diagnostic possibilities in this case. But I don't know, Jagdamba, I don't know if it's, you know, possible to.
Yeah, I think we can ask a few of them and don't hesitate to answer.
So whoever has an answer or, you know, and this is not like Nepal where, you know, if you get pulled out, you have to say something and otherwise someone will laugh or anything. Okay. So over here, we don't even do that. That's why I'm a little hesitant to make, you know, put you guys on the spot. But if you have anything, it'd be good to add to the conversation. Anyone has any? कसैलाई माइन्डमा के छ के होला डायग्नोसिस के हुन सक्छ होला हैन कुनै राइट or wrong answer हैन यो केस. It's an imaginary case. And I just made too many kind of loose ends so we can tie them up.
Maybe autistic spectrum disorder, maybe.
Good.
Yeah, like a family background, say about stepfathers or mothers. I mean, like a PTSD, post-traumatic stress disorder, like हुन्छ नि अब ड्याडी र मम्मी बिच झगडा भयो अब त्यो ब्याकग्राउन्डमा हुर्केको भयो त्यही भएर चाहिँ उसलाई त्यस्तो एउटा इमोसनल के भनौँ स्ट्रेस भनौँ न हैन त्यसले गर्दा चाहिँ अब उसलाई चाहिँ लाइक तपाईले भन्नुभयो ADHD भएर लाइक इट इज गोइङ टुवर्ड्स लाइक ओम दाइले भन्नुभएको जस्तै अटिजमतिर पनि गइरहेछ उहाँको क्यारेक्टरिस्टिक हेर्दा चाहिँ फिचर्सहरू हेर्दा चाहिँ मलाई चाहिँ त्यही लाग्यो.
ओके अरु कोही ठिकै छ अगाडि बढौँ हैन सो अब त्यो केस हेर्दाखेरि अब as a primary care level you have to understand a few things हैन first with children it's a little different than interviewing adults right because our 7 years को child उसले कतिसम्म भन्न सक्छ तपाईलाई अनि can he actually express it or not so you always have like multiple sources of information you need it for kids you need the kids for one you need the parents and then you actually also need in many a time you need the information from the school or people outside the immediate family so as to know like how is he doing so that's one difference the other thing is now when you think of someone who's 7 you try to think of all the possible diagnoses that can happen at this age well first up is he speaking well so amongst the most common concerns that they come to me is behavioral problem see they are disruptive behavior or defiant behavior and but that doesn't speak much behavioral problems can happen in so many different cases that's why I brought this up so about behavioral problems it could be maybe he can't speak I didn't tell you that he's subdued but maybe his speech maybe is not developed when you can't speak you behave poorly then maybe he is autistic like one of you said because I guess maybe he thought he's not making eye contact he's not talking to people he's isolative so is he autistic then you have intellectually disabled so speech common intellectually but maybe he is just intellectually disabled just intellectual disability cognitive practical and social domains you're behind so is he just like that across the board is his adaptive functioning meaning his ability to do his day-to-day activities is that poor this is simple depression I know he's the irritability is a very non-specific symptom. I know you could be anxious and be irritable. You could be depressed. You could be autistic. You could be, someone bullied you. You can be irritable from any number of concerns. You can have mania and be irritable. So, but he's irritable. He's isolative. So maybe he's not depressed, but irritability itself might count. He doesn't want to go to school, right? So then is he anxious? He's not making eye contact. Subdued ekdam bolna garo cha he's just anxious PTSD wale bhane jasto haina is there some trauma now I will just say that this is not uncommon so if just having a stepfather and stuff makes you have PTSD half the population will have it so it's a way of life so then within that is there something else he has to visit his father are the visitations recently less frequent? Is the father not paying attention? Did the father get another, wife? Is the relationship with his stepdad not good? Is there any abuse? One thing you guys realize there's a 3-month-old in the house. Is there jealousy, sibling, rivalry sort of stuff? Was mom's attention more so, was mom's attention on him previously and now it's shifted? So he feels kind of, a little lonely between having to shuttle between dad and mom's place and not finding someone who he feels is really caring for him. So is it just an adjustment disorder just because of the birth of the 3-month-old? So these are conditions that can present. And now, finally, there's that ADHD. There's a family history of ADHD. I said he's inattentive, he's impulsive. So what do you have to do is you have to kind of, take a very comprehensive kind of history, right? And what I always tell people is in psychiatry, it's all about the history taking and what you get out of the assessment, right? It's not like there's a lot of blood tests or there's a lot of investigations, that you have to do. And then you figure out, okay, this is it. Yeah, you have to do investigations to rule out many things sometimes. But more or less, by the time they come to me, usually they've already been vetted and checked and everything by the primary care. So they haven't found a reason and so they send. But yeah, sometimes there's exceptions. So you've got to know your medicine. But anyways, so after that, the main thing is that's why the main thing is the history. And if the history is the main thing and the assessment is the main thing, you have to have an inter-rater reliability. So someone assesses him in Nepal and I assess him here what's the common thread? It has to be that DSM diagnosis, right? Because that's, if you follow the DSM and make a diagnosis according to that DSM, then I can say for sure, okay, well, he's been diagnosed with depression, which means he has these symptoms, more or less. And so I can be a little kind of, sure, okay, we're going in this direction, or now I should try this medicine or not. So between two providers, that's the main kind of inter-rater reliability kind of thing. So you follow the DSM, you follow the criteria to the extent possible, but it doesn't mean the criteria is the end all of this. Sometimes there's just, the affect of the person is different. Sometimes they just can't speak. So you have to keep all that in your mind. So just because they're not mentioning, okay, I'm depressed, I'm sad, I have sleep problems, or I don't have, if they're not mentioning, doesn't mean you rule it out. You have to you're the one who is in the session with the patient. So you have to figure out, okay, well, looking at this family dynamic, I feel like there's a lot of stress in the family. Maybe they're not able to talk, maybe what. So anyway, so these are the main conditions that the behavioral problem may be emanating from. These may be the etiologies of it. So I'll tell you, let's see, speech, it's very easy to tell, right? I mean, if you're not communicating, it's not like from today. These behaviors should have been going on for a long time, right? So it's not just like, in the last few months, if he's been this way, what's the reason? Sure, it can be like he used to be able to handle it. Okay, now he's becoming more aware of his speech impediment. He's now feeling more downcast and lonely. As far as and the same goes for the intellectual disability. I mean, you just don't get worse all of a sudden. You'll have problems going on for a long period of time. So you can already rule those two out. Now, autism is another one. So, you don't turn 7 and all of a sudden lose eye contact. And well, there's certain conditions, yes, but you don't all of a sudden lose eye contact, become isolative. So you ask the history. Was he always like this? But maybe was he social? Did he make friends? Did he talk to people back and forth? Did he take turns during play? Did he make eye contact or not? Did he seem to understand body language well? Were there some obsessive behaviors that he did over and over and over again? Were there some fixated interests that he had, like certain things he liked to a huge extent, to an abnormal extent? And then were there any sensory issues, for instance? Is he someone who just doesn't handle change? And those are things you can only learn by the history. You look at them and then you say, because you're seeing the kid when he is subdued and now making eye contact. So you can mistake him for being someone who's autistic. So that little 30-minute session in the office is not going to be enough for you to tell. So you need the history and the background, right? So you can pretty easily rule that out with the family who might say, no, he's never been like this. He's my, social child. He's got so many friends and this and that. So you can already, tell. And you can also, many a time you can sense it. You look at a kid, you can sense it. Sometimes they're like that in front of you, but when I go outside in the waiting area, they're chatting away. Anyway, so there's autism for you. What about depression? Yeah, I mean, you got valid points. You got a birth in the family, a 3-month-old who will require a lot more focus and attention. And so, maybe he feels a little alienated. Add to this, maybe the dad hasn't been able to meet as frequently as the kid would like. Maybe he's busy somewhere. Maybe dad has a new partner. So it could be depression because you got all those symptoms. So behavioral problems can arise in this setting too. Like, so when you're depressed, what do? You don't want to listen. When you don't want to listen, someone will raise their voice saying, hey, do this. And then you get more defiant. You might also yell back, depending on how you've watched people around you. So then you get called defiant and you get referred for a behavioral problem, but it might actually be depression. And then, and similarly goes for anxiety. Now, anxiety too, normally, I mean, you would have some anxious temperament too, like as a child. Yeah, he's always been a little anxious, but it may arise out of, some other concern too later in life. But let's say he's always like he's got an anxious temperament, meaning he's a little timid. He doesn't like to try out new things. He's a little shy in social settings, doesn't open up. Behaviorally inhibited. In general, his behavior is somewhat inhibited. And all of a sudden, you're a saनो stressor anxious. So you could have, anxiety too. PTSD, like I said, I mean, if, there's abuse also, like you have to watch, he goes to school. So school ma cha ki gharma cha? That's one thing I usually want them to figure out. Or is it across the board? So if someone is behaving really well in school and then they come home and they have a lot of problems, what could be the reason? Could be maybe problems in the home, stress in the family. There's a newborn, maybe it's just jealousy issue because of that. Maybe there's, a lot of domestic violence between mom and, or mom and stepdad. So it's only happening in home, not at school. Then he goes to school. School is now a safe place for him. Or what about the other way around? It just happens in school, not at home. Where is there bullying? Is there a learning disability? Like he struggles in math or reading. And so when it's time for math, he's like, I don't want to do it. And then he becomes defiant. And the teacher just, figures out he's a problem child, and he gets in trouble even more. And now kind of, he just doesn't want to go to school because of that. And it may all be because of a learning disability. But the way to figure out whether it's a learning disability or is it across the whole school environment is, is it only mostly in certain classes like math or maybe reading? Is he otherwise pretty good? And then bullying, I said, is there any conflict with a teacher that he doesn't like? There's a teacher who picks on him or something like that. So those are things that could be the issue in school. And then he comes home and he's fine because there's no math, there's no, teacher, there's no bully who is after him, and everything is good. What about if it's across the board? School, home, every social setting. It could be ADHD. That's one of the more common diagnoses over here, at least. So it turns out it's like, he's like that in school, maybe a little worse than home, because depending on how the parents see it, what their understanding of psychiatric illnesses are too, how psychologically minded they are. They might feel that everything is okay. And if it's grandparents, nothing is ever wrong in their grandchild, right? So, but it's both places, meaning he's hyperactive, he's impulsive, inattentive. When you speak to him, it's like his focus is somewhere else. He's easily distracted. He loses things, forgets things. If he has to process information, it's very tough. If you give him like a multi-step command, hey, go upstairs, open the cupboard, bring me that book from the top rack. He forgets. Maybe he doesn't even initiate it, because when there's ADHD, you struggle with processing information. You struggle with forming a strategy in your mind as to how am I going to achieve this? So he might forget, and so they have to probably repeat it 10 times. And then depending on how the parents are, if they're too, high strung themselves, they might yell and scream at him. So it's like that at there. And then, if you have the hyperactive stuff, you're almost like you have a motor attached to you. You constantly go, 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 go. You're moving all the time. And you blurt out, you can't wait in turn, you interrupt, you intrude, you talk too much, you can't sit still. And even if you're on the couch, you're kind of doing fiddling, fidgeting, doing squirming, all that kind of stuff, right? So in general, this can happen, ADHD would happen across social settings. Now, the problem though is, let's say he's a boy and they think they've never had a boy before, these parents, and they feel this is a boy thing. This is how boys are. And to be honest, boys do have the hyperactive part of ADHD more so than girls do, right? So they might think this is normal. So how do you know it's different? You have to compare. So, you got to compare with similar aged kids who are boys in similar social settings. How does he do? And the best place for that is school. So, where they can see, okay, other boys around, and you compare them to other boys, this kid is, way kind of hyper. But if it's the inattention type, that's much more difficult to diagnose, because, you can't tell unless the teacher is so, diligent. It's a little tough to tell that the kid is focusing or not focusing. You may look at the kid's work. Is it off task? Is it careless? Is it like it's rushed through? You can tell that way. You need a diligent kind of teacher, right? So who has a good relationship with you, who's constantly focused on you to tell. The parents might be able to tell more, but sometimes I've seen parents are they're a little hesitant to accept that something is wrong until it goes to a huge extent, until it becomes pretty severe, right? And then plus the other thing I can say is, unless sometimes the problems at home might be hidden because there's more social support, especially in our families in back home. There's grandparents, there's aunties, there's uncles, whoever, and they might be able to take care of the kid or handle it. So the stress on the parents per se may not be as severe, and so the stress to make them go to the doctor might be a little less too. So those are the things that you can look into. So speech issues, intellectual disability, autism, depression, anxiety, PTSD, and then ADHD, amongst the more common ones. Okay, so then once you look at that, I mean, you can get a brief idea because it may be months before the person sees someone. So the next thing I usually do is I just let them know about little outlines of some medications you can use, right? If it's this condition or that. So for depression, depression, anxiety, PTSD, and these conditions, first, when you explain to families, depending on how much they are into medications, you always have to kind of explain, okay, these are FDA approved medications, but in children, there's not too many FDA approved medications. So, we have so we have to use some evidence based on studies in adults sometimes, or to the extent possible, we can use the FDA approved medications here. So let's say we got a 7-year-old, this guy, and eventually, let's say we decide he is depressed, then I would normally go ahead with fluoxetine, right? That would be one medication. The usual 3 medications that we play around with are fluoxetine, escitalopram, and sertraline. So fluoxetine is FDA approved for depression at this age. Escitalopram is FDA approved 12 and above. And the sertraline is not FDA approved for depression or normal anxiety, but it's FDA approved for obsessive compulsive disorder, which you can say is a very high form, more severe form of anxiety. So, if someone has anxiety, that's my usual go-to. For generalized anxiety, there's a medicine called duloxetine, which is FDA approved 7 and above. But the standard of care, now duloxetine is an SNRI, a serotonin norepinephrine reuptake inhibitor. But the standard of care is to first do an SSRI, like a selective serotonin reuptake inhibitor. So one of those 3, again, the fluoxetine, sertraline, escitalopram. But if they fail one, then you can do the duloxetine. Then we have, let's say autism. If there's kids with autism, there's a couple of medications FDA approved for irritability, temper tantrums, quickly changing moods, aggression, meltdowns associated with autism. And one is risperidone, that is from age 5 and above. So 5, also they can get these medication. And then there is aripiprazole, which is, the trade name is Abilify, that's 6 and above. So those 2 are FDA approved for the behavioral problems in someone with autism. But these are antipsychotic medications. So I would try to avoid them to the extent possible. You want to try everything else. Certainly you need behavioral therapies, occupational therapy, speech therapy, that kind of stuff. But those are the FDA approved medications. I normally go with a medication called Guanfacine, which is a alpha-2 agonist. It's a blood pressure medication, actually. And it's FDA approved for ADHD, for more the hyperactive, impulsive part of ADHD. But it can help with impulsive aggression, and it has been studied in kids with autism. And it's my usual go-to first before I move on to the antipsychotic. Of course, someone has bad ADHD, you treat the ADHD, their behaviors will improve too. So for ADHD, there's a ton of medications at this age. There's all the methylphenidate class, Ritalin, Focalin, Concerta, Tinarusa. There is the amphetamine class, which commonly known as Adderall, त्यसपछि Dexedrine, Vyvanse, त्यसमा multiple medications in that class. So these are stimulants. They affect the, in simplistic terms, more the frontal lobes of the brain where the circuits of attention and impulse control lie. And so they help with ADHD. And anyone will tell you, if you treat ADHD, your behaviors will improve if the medication works. So, of course, the younger they are, they can have some paradoxical reactions. So instead of them being kind of, treated, they might get worse too. So then we have OCD, Obsessive Compulsive Disorder. OCD ko लागि चाहिँ there's 4 medications that are FDA approved, starting with Zoloft, जुन sertraline छ, age 6, Fluoxetine, age 7, and then there's Fluvoxamine, age 8 and above, and then Clomipramine, which is not something I use often, age 10 and above. So these are medications you can play around with. So there's not so many medications out there, but you want to kind of choose the right one. You want to give as much explanation to the family about the medication, the side effects. They have to weigh the risks and benefits. The kid is very, very young. So you want to kind of, look at that first. Well, how do you choose a medication? That's another thing I try to explain. I know. So the easiest thing is, the first thing is, see, in this case, there's a history of ADHD. There's a history of depression. Let's say we feel it's ADHD. Then the first thing I ask is, is there anyone in the family who's taken a medication? Let's say they've taken a medicine and it worked for them and it's FDA approved. Bingo. I know. You don't have to think further. There's a family history of someone doing well on a medicine and it's FDA approved as well. Let's say they did well on, let's say there's a person with this one has depression, let's say, and the family history is that someone did really well on Wellbutrin or bupropion. Trade name is Wellbutrin. Well, you have a question at your hands. I know Wellbutrin halni ki na halni. And again, there's different providers. I'm a little more conservative in that case because let's say, it doesn't have FDA approval, but there's evidence that it can help. And the family, they've done well on it, but did they try fluoxetine or escitalopram or maybe sertraline? And if they didn't try, I will still probably go on that direction. But if they tried and failed, then there's more reason to try, the bupropion. So there's some medications, you have to look at the evidence too, like Paxil, paroxetine, for instance, it's good for nothing kind of thing in kids, basically. And then let's say tomorrow there's a side effect. It's like, you'll have to find a way to explain, Dr. Pathak, there's so many medications you could have tried. Why did you try paroxetine, which has only failed studies in kids? So you have to be able to explain all that. So over here, at least, it's every time you make a decision, you always have at the back of your mind that you could be in court trying to defend your decision. So you have to have a good explanation and rationale for the medications. So even for medications to begin with, it could be like, well, Dr. Pathak, did you do some counseling for the kid first? Counseling in Nagarikana, you started a medication. Let's say it's moderate or mild depression. Maybe counseling alone might do it. You have to do counseling anyway. But if it's severe depression where someone is suicidal, then you have to think, okay, we got to do medication to begin with, and he can also do counseling. Maybe in the long run, we could try to take him off it. So you want to make those, decisions. And what I've seen very commonly in my practice is they come with these behaviors. I know they are depressed, they're all that. But sometimes you claw back into their history. It turns out they may have started with ADHD. I don't know. It's so, maybe it's just common in the US. I don't know. But they may have started with ADHD. You just imagine, because they can't focus. They're moving all the time. So the parents will also have to tell them 10 times, you gotta. And of course, your mom or dad might scream at you. And you gradually become a little demoralized. Yeah, I can't do anything right. Everything I try, I have to try 10 times. My brother is just doing so well. Not this one, but my brother is doing so well. In school, someone else is doing so well. I have to struggle so much to get the same work done in that given time. And they have a low self-esteem. Then they go to school, focus is high, especially let's say math. They can't focus, they can't do the work, and the teacher is like, you haven't done it. So you get pointed out in a way, you get in trouble. Then you don't like school. You see where I'm going? So now you got a depressed kid at your hands. And when they're depressed, they might as well just kind of, refuse to follow instructions. They might just say, no, I won't do it. Many a time what I've seen is about executive functioning. Kids with ADHD, they struggle with executive functioning, like kids with autism might struggle, kids with intellectual disability also struggle. And executive functioning, like an example, if you tell a child, okay, get off the couch, go upstairs, bring me that book from, Bible going down. So bring me that Bible from the top rack. When you see what the child has to do in their mind is now subconsciously, they're processing the question, the sequence of steps that they have to take. Get up, go, open the cupboard. It's always subconsciously by rounds. And you open the cupboard, they can't process, they can't hold on to that focus. So they're like, I get up and then go get what? Go where? And it's easier to not even get off the couch. So that the first step is initiation. So initiate it's so taxing. It's so many things. First time gorla, second time gorla, and then they get in trouble and then they're yelled at. And so after a while, it's like, no, I don't do it. I don't want to do it. And you may form a defiant face because you don't want to deal with that stress of constantly failing. Anyways, let's say they get off the couch. Now they have to remember. So they may not remember the second thing or the third thing. Let's say they get upstairs to the cupboard. It's like, what was it? Was it a book? Was it a toy? What did they want? Let's say you open the top rack. Let's say the Bible is not there. So you have to have some cognitive flexibility to maybe look in the third rack. But they don't have that, because if you just think a little bit this way or that way, your focus is gone. So they're very tight in that, focus. So they're very rigid. They look, they don't find it, they come back. Well, let's say they come back 10 minutes later and they still don't have a Bible in their hands. And so your parent is like, this will take 30 seconds. What's going on? And they might feel defensive about it. You might see that these kids will actually then react with some anger. Like they'll try to say, it's not my fault kind of thing. So there's your behavior now. So instead of repeating this step over and over again, it's much easier to say, no, I won't do it. What do you want me to do? I won't do it. I'm going to just play on my, Xbox or something. So, and then you get defiance. So it's very common to have kids with ADHD go on to develop behavioral problems. Same as in school. You're struggling, you can't, get your work done. And then the teacher is like, what's going on? And so after a while, you're like, I don't want to do it. And then you feel like, okay, this way, at least it saves you from the trauma. So ADHD goes on to then have oppositional defiant behaviors. And gradually you get depression. Like I said, it affects your self-esteem. You get depressed. So you get depressed. And then you got anxiety. Every time you go to school, you're anxious. Math teacher, you're anxious. And then in college life and stuff, you can go on to develop like addiction problems. In adult life, you can actually go on to develop antisocial personalities. I've in fact met some people who they've come to me, and when I've looked back into the past history, turns out it all started with ADHD. They were high school dropouts. They never did well in school. Lots of anger issues, very poor impulse control, meaning do something and then think. Yeah, but they don't even think, they just do something. And then they get in trouble. And then as they're behaviorally, they get pointed out, oppositional kid, defiant kid, others don't want to play with you now. So you get a little lonely, a little depressed, you act out to get attention. In college life, someone gives them like an Adderall or some stimulant somewhere, and they realize, oh my God, this helps me so much. Or they can get hold of some other stuff. Yeah, marijuana is so common, for instance, just to calm their mind down, calm their racing thoughts down. And then they get into adult life. I mean, they can't hold jobs. They can't meet obligations on time. They can't do their finances on time. And they get antisocial then, gradually. And they end up in jail. And I've seen people in jail, and go back, and it turns out it may have been all started from ADHD. Now, of course, other things have taken a life of their own, depression, drug use problems. They've changed everything, but it may start off, from a very early age with just ADHD. So those are some of the things.
Is there any role of behavioral therapy for ADHD?
Okay, so well, the behavioral therapy, there is a role, but you reach the ceiling pretty fast, because what can you do? You basically have structure and consistency throughout your lifestyle. So from morning to evening, you have a very structured routine. You keep stuff in the same spot, so you don't have to, forget. If that Bible is always in the same spot, then it becomes a learned behavior now. So like, if every day at 4 o'clock, you have to do this chore, at 5 o'clock, you have to do something. So it's like, it's automatic. It's like a robotic lifestyle in a way, but that's what keeps them from getting overly overwhelmed. And then they do better with hands-on and visual cues. So try to use stuff on the fridge or on the dresser just to help them know what the day is like today. What's the plan for today? 5 o'clock, 6 o'clock, 7 o'clock, everything like that. When you have a lot of tasks, you break them down. So, what you'll see is a lot of people with ADHD, they're classic procrastinators. They just delay. Right? So what happens is work piles up, and then it becomes a stack, and it's very difficult to do it. So you break them down, break the instructions down, one at a time, give them a break, move on to the next. Yeah, anyone who has a kid with ADHD, you'll know that you have to be on them all the time. Explain one thing, hold on, and then move on to the next. So you can kind of avoid some of that by just breaking down instructions, keeping the instructions really simple. And again, structure. You have your room should be really, simple, clutter-free, not too many toys, not too many, things lying around. And if there's stuff, you just keep them in the same spot. So that is what's going to help. But what I've studied is, whatever therapies they've done in the lab, it hasn't always translated to benefit in the real life. But this is, that you reach the ceiling pretty fast. And now a therapist may use 10 sessions to explain the same thing, but this is what you got to kind of, aim to do.
Yeah, that was amazing. Thank you so much, sir, for letting us know about the spectrum of disorders, behavioral disorders. Now, just on the other hand, I want to ask about this stubborn behavior of the children. Like, it may be uncommon in that part of the world, but in Nepal nowadays, after the post-COVID era, it's the second lockdown here. Due to this, online education have started. Now the kids are right onto the mobile for the online classes. Like they are addicted to this technology, and due to this, the parents are carrying on with the many behavioral disorders. Like they feel irritated, they feel like angry at the parents. So what kind of behavior is this about the children, and how can we minimize these types of disorders by early intervention by the parents themselves or any kind of therapy?
Yeah. No, so this has been an issue here in the US as well, because we've had lots of people doing home distance learning, it's called. So they're staying home and doing all that. And this leads to a lot of problems, especially if the parents work. And, if it's a teenage kid, now they have to motivate themselves by themselves. There's no one like supervising them. Even for others, it's very difficult. It's okay for us to be on the screen like this, but for kids, their natural coping skill is running around and social interaction and sensory stimulation. So now they don't have their natural coping skill. So it's leading to a lot of problems. Now, what can you guys do? What can we do is, like I said earlier, so I didn't say this. Let's say there's a trauma. Let's say there's like a disaster, a natural disaster, like an earthquake, which we've had in the past, right? So the first thing that parents need to realize is the kid sees the world through you, through your eyes. So if your eyes are very stressed, the kid will be stressed. If you're not the eyes, I mean as a person, if you're very stressed out, you're worrying all the time. Oh my God, what's going to happen? Imagine the kid is going to be, equally traumatized, even worse. But even the worst of disasters, if the parent is calm and they can contain their anxieties away, they're not so anxious in front of the kids, they can contain themselves, then the kid sees that calmness in them and they are more assured. So amongst the first things, in disasters or in traumas is you want to try to go back to the normal routine, right? Normal bedtime routine, normal wake up routine. So that's a sense of normalcy. It gives the kid a sense of normalcy. Okay, I'm sleeping on time, I'm waking up on time, I'm doing this and that. Well, that's in a disaster. Is the COVID just a situation? What can you do? The idea is, how much can you invest in the kid? How much time can you invest with more one-on-one attention and trying to get them, maybe you can't get them out, but you can engage with them. I've been telling parents, use this time to, get some learning, like some baking, gardening, or teach them skills that they might, make use of in later life. What I would say is, 2 hours of electronic time outside of learning is the most they should have. Outside of that, it is really up to the parent to invest some time, because these are not things like, even if they go to a counselor, the counselor will teach them some coping skills. Counselor will teach them some ways to handle stress, some breathing exercises, maybe some muscle relaxation exercises. But, they may not do much for a kid unless, there's a lot of parental involvement and they utilize this time in a way. What I tell parents is maybe use this time as a sort of a opportunity to engage more with your kid. Just because we have a kid doesn't mean we're always so close to them. For instance, I never felt so close to my father. So, you use this time to make more bonds, do things together, do cooking, gardening, baking, learning things, together to the extent you can. But remember, we're robbing them of the natural, coping skill, exercise, physical social interaction. So something like this might also help getting them on board with like-minded peers. I know the same, just to satyaru junsa, giving them like an hour or half an hour of time just to engage so they can socialize, chat away without maybe parental, involvement for a little bit is all okay. You have to just be very innovative and finding ways to kind of, manage this, because there are no easy answers. But the only thing is you still try to get them to exercise so they can, tire down and they can sleep well. You sleep well, eat well, exercise, try to maintain that same routine. But that socialization part is so important. So, if you can go out, then some way, some forums like this is perfectly good. You don't want to spend any more time on the electronics than you have to, and then use the time to bond better.
What about the medical students? Yeah, go ahead, Prashanna.
Sir, we have a question from Raksha here on the chat. A 13-year-old boy whose mother suffered from stroke 6 months back led to left-sided hemiparesis. He was good at his academics and playful. However, after that incident, he hasn't been able to get along either with studies or social interactions. He keeps himself confined in a room. Anyone who tries talking to him, he doesn't speak at all. Also, he doesn't come closer to his mother either. What could have really gone wrong in this case? The question is also available in the chat, sir.
So on the face of it, this appears more like perhaps someone with depression, unless this has been going on for a long time. But like you were saying, after the person suffered a stroke, his behavior changed. And then you add the symptoms together, you look at, if there's anything else, is there some, as a consequence of that, of his grandmother, is it a grandmother you said, or grandfather? Grandmother having stroke, what behavioral change, what changes have happened in his life or her life? And then you see like the
mother.
Oh, is it mother or grandmother?
Sir, mother.
Oh, mother. So yeah, this looks like someone who is depressed. Now, is the case, ma'am? See, when you're depressed, what do you normally do? You like to, you isolate yourself. You don't like to go out, you don't exercise much, your routines go haywire, you're not sleeping well, you're not eating well. These are all things which you need to change if you want to be better. So amongst the things that, they have to do is, as opposed to isolating, you want to talk more, you want to open up, you want to talk more. Now, again, that's the nature of the condition itself. The depression itself will make you like that, where you don't want to talk, where you don't want to kind of do stuff. So there's a direct connection. And, cognitive behavioral therapy, for instance, is a type of therapy which tries to address these things, right? So there's a direct connection between a person's thoughts, what they think, a person's behavior, and their emotions. I'll give you a quick example, so you can use that kind of example elsewhere. So, but in this case, by the way, I would say you should look into counseling as well as medication if it's to that extent. When does a question of medication arise? Either depression is very severe, where they're suicidal, or if they're not suicidal, they are so depressed that they are avoiding their day-to-day activities to a huge extent. They're not taking care of their ADLs, they're grooming, going to school, doing activities in the home, and it's affecting, them as well as their family. Then I think, at that point, you look into medication as well as counseling. As far as the counseling goes, these three things go hand in hand: emotions. And you guys might know it, or so if you know, I'm sorry, I'm just preaching to the choir. But let's say you got someone with social anxiety. Okay, so the example I'm giving is, let's say I'm a socially anxious person, and Prasanna, calls me and says, Dai, let's go to this birthday party, Rohit ko birthday party, let's go. I know. So if I'm a socially anxious person, in my mind, the moment you call me and say, let's go to someone's birthday party, in my mind, I'm thinking, my God, there'll be Jaga, there'll be this person, that person, so many people. What are they going to look at me? Am I going to be dressed okay? Are they going to make fun of me? Will they stare at me? Will they make, So I'm already kind of thinking of all these things. And then I basically tell you, Prasanna, I think my mom has some work for me to do. So you guys go ahead. I'll finish up my work and I'll catch you some other time. Sorry. So in this example, when you call me, I was thinking of all these things in the back of my mind. I was not telling you that. Those are automatic thoughts that have crept in, negative thoughts. Will they like me, not like me? What are they going to say? And those thoughts lead to these emotions. In this case, it's anxiety. I'm stressed. I'm anxious. I'm worried what's going to happen. And the behavior is that I just avoid going to Rohit's, birthday party. So what my mom can do is, let's just go, or my dad can take me 5 minutes, 10 minutes, come back. At least do some. So the easiest thing to change is that behavior part. The others will take time, but the easiest thing to change is that behavior. Behavior is exercise. Behavior is going out. Behavior is just hanging out with friends for the sake of it. Behavior is watching movies with friends, anything. So in that earlier, in the case that you said, the person can try to engage in some ways. The friends can just come in the house and watch a movie together. Even that is, just a mild change. So what happens is when we're depressed, our minds, our thinking process changes. It's clouded. It's a different day. Like today is a wonderful day here. I wake up, I'm happy. If it's cloudy, even my thoughts kind of change. So depression makes you feel that way. Your thoughts change. They're negative. It's like you're a little hopeless. You don't see much light at the end of the tunnel. But this all can change. When your mood is better, all this can change. So basically, the easiest thing to change would be that behavior part. And they're interchangeable. You change the behavior, your mood, your thought process, everything can change. Exercise is amongst the easiest way to change it. It releases happy, you can say neurotransmitters in the brain in a way. There's a break in the thought process. When you're depressed and anxious, you're thinking and overthinking. There's a break now because you're exercising. Even before you realize it, after like 10 minutes of running, your thoughts, they break away. So you want that break, and you want that break to be more and more and more. Think of it this way, like if someone loses a family member, you grieve after that person 24/7. A month later, maybe it's like 20 hours. A year later, maybe it's 7 hours. But the time is less and less and less. And so the lesser you worry about that, the less effect it has on your emotions. So you have to kind of, look into, you think of it that way. So try for the CBT, the cognitive behavioral therapy, but you probably also might need to look into, if it's been so many months, then look into medication.
Thank you, sir.
What about a screen dependent overuse in medical student? I think that is a recurring question. Oh, we talked about only for kids. What about young adults?
Yeah, young adults, it's again, it comes down to personal discipline, So unless you're depressed and stuff, there's no reason you shouldn't be able to follow personal discipline. And that again, as adults, we all know, okay, this is causing me a problem. So some of the things we tell kids, it's not like they don't apply to adults too. I mean, it applies to me, I know that. So if you see, the path to success, the path to well-being, it has to be through personal discipline. You may have all the talent in the world, but you have to have that personal discipline, which means you have a regular sleep time. Now, in kids, there's a number as to, if you're so much age, you have to have this many hours. But I mean, it's safe to say 7 to 9 hours or 8 to 10 hours would be, for most adults, average of, maybe 8 to 9. So if you don't get that much sleep, that's a problem. So you want to follow sleep hygiene before that. So half an hour, 45 minutes before bedtime, stop all electronics. Don't have a phone next to you in your room or under your pillow, because if you need an alarm, we just buy one alarm. And that's the old thing. Old lifestyle is not, it's not without benefits. You just buy an alarm. We always feel someone will call us, someone will do this and that. Well, I'll tell you what, if I could invest in something, and like I pay some money and I get something back, I would invest in sleep, because it's so important. And, some of us don't sleep well. So sleep, it starts with sleep. If you don't sleep well, you're not well rested. You're not well rested. You're more irritable. You're more bound to do the same thing. So you sleep well, appetite, you eat well, you exercise. And for kids, I mean, it could be 30 to 60 minutes. I mean, depending, but for adults, at least 30 minutes a day of moderately intense physical activity, at least 5 days a week. You want to exercise, and the discipline means structure in your day-to-day life. When we used to kind of listen to our parents, and they're always trying to make this structure and that structure. But guess what? I think that is how we need to be. You structure your life. You wake up at a set time. You do what you're supposed to do. You take breaks in between, and then you exercise. And then I was seeing one video where I think Dr. Koirala was talking about all those coping skills and deep breathing exercises, and those are all they apply to adults as well. I sometimes do that when I'm when I'm driving, right? So like I'm on the traffic light and I'm tense. I can do like a deep breathing exercise there. I do diaphragmatic breathing, for instance, right? So when you normally breathe in the military, they're like your chest out, tummy in, right? Over here, you can do the opposite. When you breathe in, you get your tummy out. And then when you breathe out from the tummy. So I do that. You can do that in your car. You can do muscle relaxation exercises where no one can actually see, just to de-stress if you're stressed out. You can start with any part of the body, like the hand, for instance. This one, for instance, all you need to do is count till 5 and gradually kind of, do that. And then gradually 5 and then come out. And basically deep muscle relaxation, it can start from the heels all the way, work all the way up until the whole body. But you can do these exercises. But I think the main thing is living life like someone with autism lives. Structure, consistency, sameness, in a way that at least that would keep you focused on the job. So I don't think there's any correct answers. Every person is different. But I think you get the sense what I believe. It's more self-discipline, exercise, sleep well, eat well, hang out with the right crowd.
Yes, sir. That was fantastic answer. So talking about the substance abuse in the childhood, like addiction to smoking, alcohol abuse, how can they affect the behavior of children? Like they will be indulged in such type of habits, and which can affect their behavior later on through the timeline they go. How can we educate themselves as well as parents, public, about the substance abuse?
Yeah, so amongst the things that Dr. Silberman asked me when Jago, when I interviewed at VCU, is that there's a family history of substance use too. So if you have a mom and a dad, or one of them who has a drug use problem, the chances that you might go on to develop a substance use is going to be much higher than someone who doesn't have a family history. And maybe it was a little relatively new kind of thing or something that came up. And so he was asking me about that. But anyways, this is very true. So if you have someone in the family who has substance use problems, you're at more risk. That doesn't mean there's a magnet that will pull you to, to a drugstore or a bar where you have to drink. What it means is you're going to have to find ways to avoid that, number one, more so than your other kids. So, if you got friends, there's some pressure sometimes, peer pressure, and you might slip into tobacco use. Nothing might happen to your friend because, maybe he doesn't have as much of an addictive kind of lifestyle or history, and you might get addicted. So the number one thing is, if there's a family history, first thing is you got to try every precaution not to kind of go that path. Number two, I think, is access too. How much access you have. If dad drinks or dad smokes or there's, cigarettes available in the house and stuff. So access really matters. You want to kind of avoid all kind of access. Number three is there any comorbid condition? Is there some ADHD, for instance? Like I was telling you earlier, kids with ADHD go on to develop impulsive behaviors. One of them could be, substance use. Is there some background, some depression making you kind of feel like I'll get something out of marijuana or alcohol? Is there something like that? In which case you treat that. And finally, there's medications and, there's counseling options for the substance itself. For tobacco use itself, there's Z-Band or basically bupropion. As an option. There's nicotine gums and stuff. There's a medication called Chantix. See, I haven't used all that. I basically, if anything, I would suggest the bupropion. If someone is depressed, let's say they come to me and they're also smoking a lot, and they have focus problems, and it's bingo. It's usually Wellbutrin. And even if they are like an 11-year-old, 12-year-old, where they don't have so much evidence, but that's a good medication I would go for. For alcohol, again, I can't imagine that they can be so addicted, but there's got to be a family issue there. If a 12-year-old or 13-year-old is addicted to something, you can't treat the kid without treating the family in that case. So you may treat as much as you want, but the dad is just addictive. Doing something. He is abusing maybe someone. You go into the house, you're depressed. There's got to be some background. So look into that because treating a kid always involves treating, the family in some way.
Many questions from the students panel. From Sunil, we have a question from Sunil. He says that a 14-year-old boy plays cricket while batting and feels like the shadow is approaching towards him, and the shadow tries to enter inside him.
Prasanna, I lost you at some point. Can you repeat it?
A 14-year-old boy plays cricket while batting. He sees his own shadow and feels like the shadow is approaching towards him and tries to enter inside him, but it isn't really happening so. This distracts him and he can't really concentrate on batting. He's having this problem for 6 months. So what could be the problem with him and how can we manage the case?
Well, so in psychiatry, again, the first thing is the history. You want to look into the background, right? So you want to at least look, is there a family history of something? So, the first thing that strikes your mind is there some kind of psychosis, right? The moment you see, okay, there's a shadow and then this is going on. But so one thing, of course, a family history, if there's psychosis or not. But many a time, let's say someone is intellectually disabled. Their comprehension of reality itself might be a little morphed, a little different. Let's say someone has bad PTSD. You can have, different perceptual experiences, because this is a perception, right? So such abnormal perceptual experiences can happen with trauma as well. Those are the main things I would look into. And then you got kind of, depression, anxiety, bad depression, bad anxiety if you had, because you can have psychotic-like symptoms in association with different conditions. And I would, at a young age, I would think it's more the other conditions as opposed to like a primary psychotic condition. So he feels like there's a shadow, and he's been having this for like 6 months or so. The questions to ask would be, are there experiences like this outside of, when he's playing? Is it at home only? Is it at school only? Is it across the board? Did something happen 6 months ago? And then, is like any traumas or something, maybe some trauma on the field itself. Is he an anxious kind of a person? Many a time I've seen kids who are really anxious, high-strung, anxious, or they could be depressed, and they have these perceptual experiences where they're not truly hallucinations. They're more like illusions. Illusion and hallucination, the difference is, in illusion, there is something. There is this thing, and I might imagine it to be a ghost, but there's something out there, and we morph it in our mind. And in hallucination, there's nothing here, and I imagine there's a ghost or something over there. So many a time I've seen kids who might be really depressed or maybe anxious, and they might read more than there is. They might see something and they might worry more so. A shadow, does he see a shadow, and then he makes more to it than there is? If you are traumatized, if you're depressed, anxious, if you also have, like, let's say if you're intellectually disabled in some way, or speech problems or something, your perception is a little different than the average person. And you might read more to it than there is. So, and there might be just hallucinations, but it could well just be a state of the mind kind of thing. But,
also, the nuance that I'm going to interrupt. So kind of, you have to look into, does he have any other neurological signs and symptoms? Is there something organic going on in the brain? If it just started, those are the things that you have to always rule out as well, right? If it's a nuanced psychosis, we always try to scan the head and see if there is something organic to go full workup before you say it's schizophrenia or any chronic mental illness.
Yeah, so if there's been no psychotic symptoms like this, and there are, just one hallucination doesn't make you psychotic, right? So you see about the other symptoms. Are they having these other concerns too? How is it affecting their day-to-day life? Is it just on the cricket field, or is he in general kind of odd and somewhat disturbed, disorganized in his behaviors or in his speech? Does he appear like that? Does he even appear like he's responding to internal stimuli? Now, let's say we do decide, okay, there's other things might be there, but psychotic symptoms appear to be more at the top list. Then you undergo a full workup, and as part of the workup, like Dr. Jagdamba said, you do like a CAT scan or an MRI of the head, amongst others. You rule out thyroid problems. You do a CBC CMP just to make sure there's nothing else going on, and depending on other deficits, if there's neurological deficits, mild deficits in any form, is there seizures, anything like that, then you investigate things like that. Of course, I'm just speaking from a psychiatric standpoint, but when those happen, the first thing is you do a whole panel of everything, right? If there's concerns of STDs or something, you do an HIV, you do an RPR for syphilis, you can rule everything out. You may have to individualize it to how young a person is and their social circumstance. Maybe no need for HIV, depending on, maybe no need for, depending on if they have, is there seizures? Is there any history of seizures or something like that? Then you investigate for that. A CAT scan of the head is amongst one of the bare minimums, I would say, if it's a first onset psychosis. And the average, the thyroid panel, the CBC, CMP, those kind of things. Drug screen, of course, I forgot. A drug screen if they're at that age where you suspect, and even if you don't, many a time you'll find maybe they overdose on something. Now, this is going for 6 months. That's why it's not so acute, but nonetheless, you want to kind of rule that out, at least to start with.
And it's very common in our part of the world is neurocysticercosis, tapeworm in your brain, kind of, or any eggs or that's the most common cause of seizure. So you want to kind of look into where they are at, what is going on. And again, one shadow is not going to explain. And the other part is there's a lot of, again, I think we can go on and on about developmental issues, developmental disorders, what is the cause of autism, what are the cause of AD, like fetal alcohol syndrome, or if drug use during their pregnancy time, were they premature, was there any hypoxic injury, like it goes on. I think we have to invite you again, Prem. Is there any other questions? We are also time पनि हुन लाग्यो के छ अरु प्रसन्न रोहित?
We have one more question. It's from Smita. Like she has asked about how can I help someone who knows he has anxiety, but due to current pandemic is unable to reach for proper consultation or medicine if required. Like this.
How can
someone has anxiety?
With anxiety?
Yeah. How can that the related person can go for the consultation that for the anxiety related problem? Like he's getting problems, but he is not aware how to solve it.
Right. Well, see, many a time, I think in our part of the world, it may start with like somatic symptoms. It may start with, mero headache boil, mero yo chati dukhyo, yo boil, tyo boil. And you can, I mean, that could be a good start, because if the question is more about the taboo or the stigma associated with, going to a psychiatrist, it could start off with at least thinking about, okay, these are pains, you can investigate them, but if you don't have anything, can we maybe at least talk about, because many a time they don't even know as to, this might actually be a symptom of anxiety. Many people are not willing to kind of, consider, but one of the features of anxiety are these somatic symptoms, headaches, feeling on edge, chest tightness, stomach aches, that kind of stuff. So you can start off, you can investigate and waste a lot of money with, finding a cause for them. And when you don't, I mean, they might be a little bit okay with that. The short answer would be, again, I don't know in what context the question, is being framed.
What's causing the anxiety? What is the underlying issue that is bothering them? Are they scared they are going to die because of COVID? Are they scared of losing family member? Are they scared of not graduating on time? Are they scared of failing? What is causing? And what is, again, Dr. Patakle said, cognitive behavioral therapy, that you can approach it in a way, okay, there's an event. Okay, pandemic bhayeko cha, and I'm failing, or the school is not starting, school start bhaina. And then what does that say about, malai kasto feel bhairacha, maile ke soche, automatic negative thought, oh, I'm not going to pass. Why does it happen all the time to me? And that brings a negative feeling of, oh, that's where what is a cause? You have to kind of what you can do. So that's it. Also, is it affecting their daily activity? Again, are they able to function at all? Are they having recurring intrusive thought about death and dying or losing a mind? And how can you do it? Is checking on them, asking them to keep a journal every day, ask about mood log, anxiety scale, and what is the automatic, what are they telling themselves? And that the cycle, how can they break that cycle? And asking AD, the simplest thing is, hey, let's make a team and start exercise. So you check on them, hey, did you do this? I did it. Any group, that's the other way around that you can, does it make sense for you?
Yeah, well, let me add something to that. See, what I would encourage, all you guys to do is develop your own kind of way of critical thinking. And it starts with actually asking to yourself, why is this person not wanting the consultation, let's say, or not wanting to go somewhere, or not seeking treatment? And because it's not like a book where it has all the answers. When you try to dig a little bit, there might be trauma, there might be a stigma associated with it. There might be, the family is not psychologically minded, so they might, there's different things that could happen. Maybe they don't want to be made fun of amongst their friends. Maybe a quiet consultation somewhere. I know. I was just there. Maybe going to a clinic itself is a problem. And so maybe a consultation like talking like this, for instance, or maybe a close, well, I would not suggest so. Sometimes, I've had to do like an assessment of a close family member, and that doesn't usually go well. But in general, if you know someone, I know Jaga, so I can kind of say, how about you see her? And, there's a bit of familiarity there. Although it's a double-edged sword. I've seen some kids who, who are of children of people I know, and they don't treat me the same way others would do. So anyways, but the question to ask is why? Why are they kind of, doing this? Is there something like that? And you'll begin to find answers there. So maybe it's just stigma, or maybe it's just lack of recognition that this is anxiety. And so you can, with your knowledge, you can explain, okay, well, anxiety can happen in this condition too. It's not just like, when you're like they show in the movies and stuff, like, so when you start that way, then you'll find an answer, and then you can kind of claw your way back and use your knowledge behind that.
Yeah. Thank you so much, Dr. Prem, for coming here and providing us with answers of many of our queries. And yeah, we had a lot of discussion on this behavioral disorders about childhood. So thank you so much from every one of us. And we'll be hoping you here again soon. Thank you.
Welcome.
It was a very good session, nice. एकदमै राम्रो लाग्यो हैन जियोस सुन्नलाई हैन एकदमै धेरै कुरा थाहा भयो जियोस सरको हैन कुराहरु सुनेर चाहिँ it was a good session today and I hope the participant also enjoyed a lot हैन आज चाहिँ
Okay, thank you.